day 3 of IAPCON 2022, and we are on session 1. And this session is on instruments. We all need instruments to take our work and do it to the best of our ability. And when we say that as palliative care physicians, we do excellent symptom control, that is when we need to have the best instruments. So this session is designed for us to know how to use our instruments best and how to assess our patients really well. So we are very, very honored to have two eminent chairpersons for this session. Dr. Pushpalata Gupta, she is our first chairperson, and our chairperson here is the head of the Department of Anesthesia, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur in Rajasthan. Her affiliations are to the Indian Society of Anesthesiology and Indian Society of Critical Medicine. She has more than 20 years of experience in onco-anesthesia and in palliative care at the Tertiary Healthcare Center. She has multiple publications to her credit, and she is a principal investigator in the global narcotic trials. Welcome, Dr. Pushpalata Gupta. Our second chairperson for today is Dr. Lulu Matthews. Lulu ma'am to the entire palliative care fraternity. She is the chairperson, Board of Examiners for the Indian Association of Palliative Care. She is the program director for academics at the Institute of Palliative Medicine, and she is the teacher for generations of palliative care physicians. We welcome both of you, and I request our chairpersons to introduce the speakers and take this session ahead. Thank you very much.
Thank you, Dr. Vidya, for my brief introduction. I'm sorry that my video is not running, but I will introduce briefly. I'm clear. Very good morning to all of our delegates from different parts of the countries and from abroad. And today's, as Dr. Vidya already said, today's last day of our conference, IAPCON 2022. And in this morning session, we are going to discuss different tools to measure the quality of life, distress, dyspnea, pain, etc. for next 90 minutes. In this session, total 6 speakers are there. And without delaying, I am just briefly introducing our speakers. First is Dr. Megha Pruthi. Dr. Megha Pruthi is Senior Consultant Pain and Palliative Care Specialist, Max Super Specialty Hospital, Delhi, NCR. She is having experience of 11 years. And she is reviewer. Yes. She is a reviewer of Indian Journal of Palliative Care. She is convener of supportive oncology. And she is the member of expert committee of integrating palliative care in undergraduate medical education in India. It is very important. And she is contributor peer reviewers of BMG group of Indian palliative medicine. Then she is recipient of very honored this APNH award, Asia Pacific Hospice Network Brusserie Award, 14th Asia Pacific Hospice Palliative Care Conference in 2021. She is the author of various national and international journals. Dr. Megha. Next is Dr. Aarti Hota. She is from Bhagwan Mahavir Cancer Hospital and Research Center, and she is senior psycho-oncologist and HOD, and she is very understanding and very contributing with the patients and psychological support giving. And she's having experience of approximately 6 to 7 years. Next slide, please. Next is Dr. Avnish Tiwari. He is a senior palliative care physician, Department of Medical Oncology, AIIMS Raipur. His experience of 5-year experience, and especially he is interested in prognostication and in palliative care in the sickle cell. This is a little bit different, sickle cell disease and renal supportive care. And he has achieved EAPC 2018 grant recipient, and he is invited as a faculty in ASCO 2021 and palliative care, integrated palliative care program in sickle cell disease, AIIMS Raipur. He is having 2 publications. Next, please. Next is Dr. Puneet Rathore. He's senior resident, AIMS Delhi. He's having 5 years of experience, and he's interested in pain and end-of-life care, pediatric palliative care, and he's also the recipient of the Bruce David Gold Medal 2017 and Best Paper Presentation IAPCON 2020. And he's faculty in the different palliative care programs and 13 publication, national and international. Welcome, Dr. Puneet. Next is Dr. Nandan Chaudhary. He is senior resident and as Academy of Health Science, Shija Academy of, it is a public private institute. He is having 6 years of experience and he is interested in pediatric palliative care pain management. He started this palliative care medicine department in Shija Academy of Health Institute, and he's trained in many healthcare profession. He has trained, and he has taken part as a faculty in the various awareness programs regarding palliative care, and he's having 10 publication in national and international publications. And our last speaker is Dr. Kunal Rajan Vinayak. He is assistant professor, Department of Palliative Medicine, Varanasi, and Indian Association, present affiliation is Indian Association of Palliative Care. His experience of 6 years, and especially pediatric palliative care, the home-based palliative care. He is more interested in the home-based palliative care, and he established home-based Zoom teleconsultation for the home care services at this institute, Varanasi, and he's working on establishing pediatric palliative care at AIMS Varanasi. Thank you, and welcome, Dr. Kunal.
Good morning, ma'am, and thank you so much for the introduction, ma'am. Thank you.
Thank you.
Very good morning, everyone. And here we are in this exclusive session about palliative care instruments. And I will be discussing about Edmonton Symptom Assessment System, which has stood the test of time, say, for the last 32 years. And this has been the most commonly used symptom assessment tool by palliative care physicians all around the world. I will also give you a little glimpse about palliative care knowledge questionnaire basic. We all know that symptom management is the heart of palliative medicine. So we all want a quick and holistic assessment of symptoms by a very simple tool. So that was the basis, and Bruera et al. Developed ESAS in 1991. When it was developed way back in 1991, it had, they considered almost initially 8 and then finally 9 symptoms over a 100 millimeter visual analog scale. There were actually 10 scales. The 10th scale was for any patient specific symptom. The time frame was not recorded, and Bruera et al. Would measure and assess the symptoms at 10 a.m. and 6 p.m. Ideally, this assessment should be done by the patient himself. That's a gold standard. However, if the patient has any, is not in the capacity, so the caregiver can help, the nursing practitioner or the healthcare professionals can help. So they also calculated a total symptom distress score, like a total out of total of 800 or 900, the total score. And they would also graphically represent it like this so as to know the trend very, very clearly. The 9 symptoms that they measured were the pain, activity, nausea, drowsiness, appetite. The shortness of breath was the 9th symptom that was added later. Then the depression, anxiety, and the sensation of well-being. Over the last 32 years, ESAS has undergone a lot of modifications, permutations, combinations, and many authors have suggested more symptoms into it. One important prominent revision of ESAS is the ESAS revised, and there are majorly 6 changes that have happened. The first one being that the time frame is now. Then there are a few definitions that are added because, you know, even the healthcare practitioners and the patients were getting confused as to what is tiredness and how is it different from drowsiness and others. So they have added some explanations like tiredness is lack of energy, drowsiness is feeling sleepy, then depression is feeling sad, and anxiety is feeling nervous. Well-being is how do you feel overall. Then they also changed the appetite to lack of appetite. It may give it more of a symptom orientation. And in the 10th one, they gave an example of constipation. Then you can see that in this NRS, there is no horizontal line here. Then the shading of gray and white. And the symptoms were also clubbed together, similar ones like tiredness, drowsiness together, anxiety and depression together, and well-being was kept at the end to give an overall impression. And overall, ESAS is a great tool. It's comprehensive, it is patient reported, it takes less than 1 second, it is validated and free of cost available. So it's a great tool. And this is the ESAS R Hindi and Punjabi versions. So, and it can be very easily used, it can be our kind of the starting point when we are assessing the patient in our OP visits, IP visits, home care. It is very easy to monitor the therapies, the trend is visible. And in many institutes have used touchscreen kiosks for measuring these. And in fact, we at Max are also in process of doing this, that in OPD, all the oncology patients are being registered in the OPD, just like they undergo their vital screening at the time before they come to our OPD chamber. So similarly, there will be a symptom screening done at the touchscreen kiosk, and the same will be shown in our e-prescription. Then to trigger clinical actions like referral to palliative care, we recently at Max conducted a modified Delphi consensus for referral criteria to palliative care. And we found that more than 70% oncologists strongly agree that yes, the symptom burden is a very important trigger for palliative care referral. However, it should only complement the clinical decision of the oncologist and not be the only trigger factor and not overcome it. So it's a great research tool. It is used for to audit our interventions, the effect of interventions on the symptom management. It is used to see the trajectory of symptoms across the spectrum of the disease. It is used to see the symptoms that are clustered together, symptom modulators. Then overall total ESAS scores to examine the effect of specialty palliative care versus usual oncologic care on symptom burden. We can use it to measure that difference. So, however, there are certain factors that cause a hurdle that we are not able to use it. Like the patient, if he's cognitively impaired, there is communication barrier. The patients, somebody with a very refractory symptom, say a subacute intestinal obstruction, the patient is not passing stool daily. Then you go and tell him to mark his symptoms daily. They are frustrated. They just don't want to do it. Then the healthcare providers, they have poor understanding about the tool. And they feel that it takes a lot of effort and time, it causes a delay in their clinic time, so those things. Then overall, the tool is also unidimensional. We must remember this. There are many versions, so inter-institutional comparison may be a little difficult. Then the trained personals are needed. And also towards end of life, it's not very useful because the symptoms like lack of appetite, like tiredness, like anxiety, all these things, they do go up. And despite the best of management, the symptom distress score overall remains high. But the victory lies by overcoming these barriers. And so whenever you are trying to institute, say, this ESAS in your institution, what we need to do is we need to be open to heterogeneous beliefs of other clinicians. We need to discuss with multidisciplinary practitioners excuse me, for inclusion of ESAS and how do they want to do it? Do you want to do it on a paper? Do you want to do it on a touchscreen kiosk? And what effect will it have on patient-centered management? That is again very important. Then train your workforce nicely, tell them, give them term definitions, give them examples of how you will tell the patient about this. And of course, not just the initial training, the training must keep on going as to clarify issues that keep coming up with different people. And one size does not fit all. Like we at MICC, Max Institute of Cancer Care, have used this daily symptom assessment tool. If you can see it clearly, there are only the physical symptoms here. We have included sleep, constipation. This is in English and this is in Hindi. And we have excluded the symptoms like depression and anxiety just because, we do not have a counselor who comes on rounds with me. We do not have a psycho-oncologist dedicated to oncology department. So when we started and we piloted this, so it was very difficult. Daily the patient is marking depression as 8 and we are not really tackling it. So we thought, and sometimes we had cases like patients they will always mark it 0, even if we can see subjectively that the patient is depressed. So we thought, okay, we do assess the psychological symptoms subjectively and make appropriate referral or counsel the patient. But for daily symptom assessment, we use only the physical tools, physical symptoms. So of course, this also needs further validation, and some of the terms like depression and well-being need more precise definitions. Now over to palliative care knowledge questionnaire basics. So this is the study that was done by me, Dr. Gaurav, and under Dr. Sushma Bhatnagar and Dr. Abhay Ryan. We developed and validated this tool to measure knowledge of healthcare professionals about palliative care in India. So we all know we need aware and educated staff to improve palliative care provision across India. And till now, what tools and knowledge assessment tools we're using are majorly those which are either non-validated or they're validated in other countries. However, our nurses are different, our healthcare system works differently. So we need a tool that is validated locally. We developed this tool in 4 phases, which are item generation, content validity, pilot testing, and field testing. And we have very extensively checked it for its psychometric properties. It's a 24/5 item tool and self-administered. It takes only around 13.5 minutes to complete it, with moderately reliable KR20 values and test-retest reliability values. It is a very it's one of its kind tool in terms of that it covers the domains ranging from philosophy of palliative care to non-oncology palliative care and various aspects of palliative care. However, it has been only seen in 102 nurses of Delhi NCR and tertiary care hospital. So we need further validation studies in other populations. However, we still feel that it will find great clinical applications in our daily day-to-day assessments that we do for our nurses as a starting point for educational activity to know the need assessment, then as to assessment of the educational programs and pre-test and post-test. So I think it will generate and intrigue them to think about various aspects of palliative care. It can even be used in ASHA workers or social workers and physiotherapists in the palliative care team. And maybe we can have some regional versions to be used across India. This is the tool. It consists of around 11 domains in 25 questions. Thank you so much.
Thank you very much, Gaurav, for recording it and playing it flawlessly. Over to the second speaker. Thank you.
Good morning, everyone. I'm Dr. Aarti Hota. I'm a psycho-oncologist working at Bhagwan Mahavir Cancer Hospital, Rajasthan. In this particular session, I'm going to discuss about distress thermometer. Definition of distress in cancer, as per NCCN, a National Comprehensive Cancer Network, distress is a multifactorial unpleasant experience of psychological, social, spiritual, and physical nature that may interfere with one's ability to cope effectively with cancer, its physical symptoms, and treatment. Distress extends along a continuum ranging from common normal feelings of vulnerability, sadness, and fears to the problems that can become disabling, such as depression, anxiety, panic, social isolation, and existential and spiritual crises. The screening tool was developed by the National Comprehensive Cancer Network Distress Management Panel. NCCN panel for distress management chosen the word distress because they thought that the word distress would be more acceptable. It sounds normal, it is less stigmatizing, and not embarrassing to be told as distressed person. As we often know, uh, uh, often people worried about or embarrassed with the word psychological, social, psychiatric, and we can incorporate all domains like physical, social, psychological, and spiritual. So it is important to think about the broad range of concerns of cancer patients, number of concerns they have to deal with, coping with the physical symptoms of the disease, particularly pain and fatigue. At the same time, they are experiencing with the psychological feelings of fear, sadness, worry, concern for their family, their future, their social roles, and existential crises and spiritual concerns are there. So now it is very important when we talk about psychosocial issue, we should remember the breadth of the issue. That is, the patient is confronting. To put this in a graphic form, if we consider in the left of the slide, this is normal distress, normal fears, normal worries, normal sadness with the diagnosis of cancer. However, if we look at the continuum going over to the right, severe distress at the end of the continuum represents diagnostic categories of depression, anxiety, disorder, social isolation, and spiritual crisis. So, distress is very common and uh, it may happen with any patient who has diagnosed with cancer, any place in the world. So, distress is a global issue. Now, NCCN has fixed the standards of care for distress management. And now distress is the sixth vital signs like BP, pulse, temperature, pain, which need to check for every patient. So as per their guidelines, their standards, distress should be recognized, monitored, documented, and treated promptly at all stages of disease. All patients should be screened for distress at their initial visit and as clinically indicated. Screening should identify the level and nature of the distress. So this is very important. We should identify the level and also the nature of the distress. Distress should be assessed and managed according to clinical practice guidelines. So now the question is, how do I measure distress? How do I know what level of distress warrants follow-up? How do I get the information to someone who can do something about it? So, National Comprehensive Cancer Network developed distress thermometer. It's a 10-point scale, 11-point scales, 0 to 10. This is the algorithm, just like pain. Any score in this scale, 4 and above, of 0 to 10, that patient tells you that is the trigger to have a distress, and further evaluation and referral to an appropriate resource is necessary. 0 means no distress, and below 4, this is mild distress. This is complete distress thermometer. In the left hand side, it is distress thermometer, and in the right hand side of the page contains the list of problems. The problem area are mentioned in the 5 domains. This is physical concern, emotional concern, social concerns, practical concern, and spiritual or religious. Which supportive care services are needed is depend on the problem areas specified by the patient in the problem list. So, distress ladder management by standards and practice guidelines adopted from WHO analgesic ladder. I have explained in my earlier slide that less than 4 is the mild distress and 4 and above is the moderate to severe distress. So as per their guidelines, if a clinical evidence of moderate to severe distress or score greater than equal to 4 on screening tool need further evaluation or clinical assessment. Patients with practical and social problems should be referred to the social work and counseling services. Those who have emotional concerns or psychological problems should be referred to the mental health professional, and spiritual care should be referred to the chaplaincy or religious leader. Many patients in our country use their religious or spiritual coping resources to cope with the illness, and physical concerns definitely best managed by the physicians or medical. And any score less than 4 is the mild distress managed by the oncology team, primary oncology team, with the resource available with the patient. But in case if there is any necessary, the patient should be referred to the appropriate care. So now I can say that distress thermometer is a means to understand how to handle the patient. Now, but we know that social context and culture leads to wide variation of recognition of distress and management. Issues are very different in developing countries and developed countries. So the barriers are multifolded. In developing countries, there are limited medical resources to treat cancer and even to manage pain and other difficult symptoms. Distress is low priority and usually managed by the family, friends, religious leaders, traditional healers in developing countries. And there are very few professional resources available and lack of training in such field. So if we see the patient-derived barrier, we can find that fear of second stigma of having not only cancer, being labeled again a person with a psychological or psychiatric illness. That is very, very important in our culture. In their verbatim, patients say that I'm too embarrassed to tell the doctor. Doctor will think I'm mad. And it is not at all related with the disease or with treatment. These are the attitudinal barriers of the patients which keep them away from the psychosocial care. If we see the doctor-derived barrier, lack of time. Doctors have not much time to ask psychosocial issues. And for them, psychosocial care is not priority. And obviously, lack of training is also there. So here, don't ask and don't tell policy exists in the doctor's derived way. And limited resources limited resource available in the institution or in the hospital for psychosocial care. There are a number of barriers, but we should not be pessimistic. We have to change the things. We have to improve the situation. So, I can say that if we include the distress assessment tool, like distress thermometer, as a part of our regular clinical assessment, the situation may improve. And orientation and training of distress thermometer or distress assessment for healthcare professionals is also an important part. More and more research needed in this field. Now, the NCCN distress thermometer is freely available for non-commercial use. NCCN also has verified translation of the DT and problem list in various languages that are freely available online. These are the websites you can go and check for distress thermometer. Thank you so much. Thank you for listening me. Now I can take the question. Thank you so much.
Hello everyone. So today we are going to discuss about the palliative prognostic index as a part of discussion on instruments. Palliative prognostic index is a very fascinating tool about the estimating the prognosis nowadays, because it is basically based on various objective parameters what we use in our day-to-day life. Before coming to palliative prognostic index, let me have some background work. So since last 40 years, when the palliative medicine has been established as a specialty or subspecialty, the prognosis has always been a concern for all the physicians, especially in setting of advanced cancer. So prognostication is of importance because of its helping in the clinical decision making, to prepare for the future, enabling timely referral to hospice care or appropriate setting. There is one data that 39 million Indian people are becoming poorer and poorer because of the unnecessary aggressive treatment, especially near the end of life. So you can imagine how important the prognostication is. Prognosis can be estimated in two ways. That is, one is a clinician prediction of survival, and second is actuarial judgment, which are based on various objective and subjective parameters, but based on some or another kind of data. So in a meta-analysis by Glare et al. In 2003, they have suggested that CPS is most of the time inaccurate or excessively optimistic at times, which was actually countered by another study by Stone et al. We will see ahead. So in two other systematic reviews by Chian et al. In 2015 and Glare et al. In 2003 respectively, this shows the estimation of the clinician was consistently shown to be overestimated. So there we actually found some need of evaluating a tool which will be based on some objective parameters. So eventually during its development, different kind of sign and symptoms and laboratory parameters were taken as parameters for evaluating the prognostic tools, and each parameter were a prognostic indicators like delirium, anorexia, cachexia, dyspnea, in some studies CRP levels, sodium levels, WBC counts. So these all were actually the prognostic indicator. So there are multiple variable of predictor survival shown in different kind of studies, and different parameters has been taken, but the best model will be which will be using the objective parameters, not the subjective parameters. So definitely there is need of meta-analysis and large multi-center trials. So what could be an ideal tool, and how much accurate is accurate enough, and how much good enough is good for us? So there is two things: probability and predictability. So let me discuss about something about very superficially about some name of some tools. One is non-disease specific. Some certain are disease specific, and certain are disease specific but not related to cancer. So these all are actually it's the tools what you have shown actually we do use in our day-to-day practice, and most importantly we use PPS, CPS, PPI, and PAPS, that is palliative prognostic scores. And now PIPS is also showing its data, but it's based on various kind of laboratory parameters. So in Indian context especially, I would say that it is impractical to implement that. So every tool has their strength and limitation. So no tool is best, no tool is worst. Even the clinician prediction survival is having the has shown the quite a relevance in compared to other tools in recent study with Stone et al. So the PPS actually shows the higher predictability of survival between 1 week to 6 months. So that is quite a gross duration, while PPI show predictability between 3 weeks to 6 weeks. So that is actually more useful for us. As far as PAPS is concerned, which actually incorporate clinician predictor of survival in it, and it actually doesn't tell us the specific predictive, but it shows the possibility of living. So that actually inferiors it is compared to palliative prognostic index. So talking about the palliative prognostic index, it has been evaluated basically in hospital setting, but it has also been evaluated in hospice setting, home care setting, and we are doing a study in which we are actually validating it on OPD basis. OPD setting it has been evaluated. I am doing it in OPD basis, and the data is going to publish very soon. So palliative prognostic index is it has actually 5 domain consist of PPS, oral intake, edema, dyspnea, and delirium, and each indicator has been given marks, and it is very easy to mark the particular in this tool. So the PPI score for more than 6, more the score, shorter is the survival. More than 6 score PPI, less than 3 week survival. More than 4, less than 6 week survival, and PPI score less than 4, more than 6 week survival. So this is how it categorizes the survival. So this is a palliative performance scale which have 5 domains, and corresponding to these domains there are Karnofsky performance score on the left side. So it is a part of palliative prognostic index. It is also a sensitive and specific enough, but the applicability of PPI is more relevant in context with palliative care practice. So I will just ask you to emphasize on the specificity of this PPI, what has been shown in the study by Stone et al. And Morita et al. Respectively. So the PPI score 4, that means the survival is less than 6 weeks. That is 92% specific enough in the study shown by the Stone et al. That means the ability of PPI to correctly identify those who will not live less than 3 weeks or less than 6 weeks is high enough. So it is quite a specific tool for prediction of the survival, and the sensitivity in different kind of cohort studies, it has shown different result, and I will also share my result very soon. So the palliative prognostic index is chosen in our setting because it is most feasible, doesn't need any expertise, is based on more of objective parameters. It can be reproduced on different settings. It doesn't require any laboratory investigation, which are most of the time are unethical near end of life. And yes, it has been shown in various cohort studies that it is quite a sensitive and specific enough. Thank you so much.
Hello everyone, I am Dr. Puneet Rathore, working as a senior resident in the Department of Palliative Medicine in AIIMS, New Delhi. And today I will be talking briefly about various neuropathic tools available, but will be focusing on DN4 questionnaire, which is a simple, easy to administer screening tool. What is neuropathic pain? The definition: the International Association for Study of Pain, IASP, defines neuropathic pain as the pain caused by a lesion or disease of the somatosensory nervous system. Before going on with the tools, we must know few important key characteristics of neuropathic pain. Once the key characteristics of neuropathic pain are identified, it becomes very easy to screen and assess neuropathic pain using various available questionnaires. If a person suffers from neuropathic pain, the description of pain he gives is like shooting, lancinating, electric-like stabbing. Sensory deficits are common. For example, he complains of tingling sensation, numbness, pricking. Motor deficits may be present as neurological weakness, dystonia, or spasticity. Hypersensitivity is very common. Pain is often evoked by non-painful stimuli, which is also known as allodynia, or exaggerated painful response evoked by painful stimuli. Radiation pain is an important characteristic of neuropathic pain. Patient often complains of distal radiating pain in our daily practice. It is one of those symptoms which, when present, we term as neuropathic pain. Exacerbations are common and are unpredictable. Unlike somatic or bony pain, where exacerbation can be expected on movement, but here it is greatly unpredictable. Autonomic signs are common in around 30 to 50% of patients. Autonomic signs such as color change, temperature change, swelling are generally seen. The incidence of neuropathic is not only common in cancer but also in various non-malignant diseases. So we need to diagnose and do proper assessment of it. For diagnosis and assessment, we have two types of questionnaires. First, the screening tools, which helps us in identifying whether the pain is neuropathic or not. Once identified, we proceed with the assessment tools. The common screening tools available are the Leeds Assessment of Neuropathic Symptoms and Signs, commonly known as the LAN scale, the Neuropathic Pain Questionnaire, the Dueler Neuropathic 4 Questions, Pain Detect, and ID Pain. And the common assessment tools available are Neuropathic Pain Scale, Neuropathic Pain Symptom Inventory, McGill Short Form Questionnaire 2, and the Pain Quality Assessment Scale. It is again derived from Neuropathic Pain Scale. The topic given to me is to describe a screening tool which can be administered easily and can be used by all healthcare workers. So I have chosen DN4. What is DN4 questionnaire? DN4, that is the Dolio Neuropathic 4 question. It was developed by the French Neuropathic Pain Group by Bohaisira et al. It is a validated clinician administered screening tool. It is used to indicate whether a patient may be suffering from neuropathic pain and can be applied to a specific painful area. Now coming to how do you use the DN4 questionnaire. The questionnaire contains 10 items split across 4 questions. We work with our patient and they provide a yes or no answer to each item. Each yes equates to 1 point and each no equates to 0 points. So coming to our questionnaire, this is DN4 questionnaire. We must note the patient's name and also the date. This is the 10 items here are divided into 4 questions. The first 2 are related to the interview of the patient and 3-4 related to examination of the patient. Question number 1. Does the pain have one or more of the following characteristic? If burning is present, we mark yes. If it is absent, we mark 0. If painful cold, we mark as yes, then we give 1 point. If no, we mark as 0. If there is electric shock like sensation, we mark as 1 yes, and if he does not present with this, we mark as 0. Question number 2. Is the pain associated with one or more of the following symptoms in the same areas? If tingling symptom is present, we mark as 1. If no, we mark as 0. If pin and needle like sensation symptom is there, we mark as 1. If not there, we mark as 0. If numbness is present, we mark as yes. If absent, we mark as 0. If itching is present, we mark as 1. If it is absent, we mark as 0. The third question, is the pain located in an area where the physical examination may reveal one or more of the following characteristic? That is, if there is hypoesthesia to touch. What is hypoesthesia? It is nothing but defined as decrease in normal sensation. So if there is hypoesthesia to touch, we mark as 1. If it is absent, we mark as 0. And if there is hypoesthesia to pinprick, we mark as 1. If it is not there, we mark as 0. The last question, in the painful area, can the pain be caused or increased by brushing? If it is so, we mark as 1. If it is absent, we mark as 0. So it is a very simple tool. We have these 4 questions, very easy to administer. So how do you interpret this? At the end of the questionnaire, we add up the yes answers, giving a total score out of 10. If the patient score is greater than or equal to 4, the test indicates that your patient is likely to be suffering from neuropathic pain. So this questionnaire is so handy, easy, lesser time consuming. It can be easily administered at home setting by various healthcare professionals and also in the OPD setting by nurses and physicians. And it is handy questionnaire because it is also used for various research purposes. This table shows the comparison of the common screening tools with the specificity of around 90. Similarly, the LANS questionnaire has a sensitivity of 85, specificity of 80. The neuropathic pain questionnaire has sensitivity of 67 and specificity of 74. Similarly, Pain Detect has a sensitivity of 85 and specificity of 80. So DN4 is a very good screening tool. So what are the screening questionnaire in routine clinical practice? Neuropathic pain by physician and other healthcare professionals. The suggested screening questionnaires are the DN4, Pain Detect and LANS. For self-report of neuropathic symptoms, the LANS scale is commonly used, the DN4 is used, and the Pain Detect is used. For screening of neuropathic pain in mixed pain conditions, particularly cancer and lower back pain, the suggested screening questionnaires are the DN4, LANS scale, the Pain Detect. And screening for painful diabetic neuropathy, the DN4 is very useful. The screening of neuropathic pain after spinal cord injury, again Pain Detect and DN4 is used. So here you can see that DN4 is very common, easy, and it can be used in various disorders. No screening tool is perfect. They can be administered quick, that is 3 minutes to complete, and they're very easy to use. They're validated for use as self-report also. They can detect neuropathic pain in complex neurological conditions and mixed pain syndromes. And what about the limitations? No information regarding clinical history of pain. Often necessary examinations are absent. Under and overdiagnosis is in around 10 to 20% with more than one site of pain. The site with the most severe pain gets the attention and the questions are being focused and asked related to that site only. So this was a brief regarding the neuropathic tools. I request all those who are listening to choose any of these screening tools according to their comfort and suitability and start assessing neuropathic pain right from the start. Once in practice, it hardly takes any time to complete the entire form. Lastly, I thank IAPCON for giving me an opportunity to be a part of this wonderful program. Thank you so much.
Hello everyone, I am Dr. Nandan. I am a consultant palliative medicine physician working in Manipur, and today I am going to discuss briefly about various tools used for dyspnea. So before knowing various tools for dyspnea, I would like to explain what is the definition of dyspnea. So according to American Thoracic Society, dyspnea is defined as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So dyspnea is a subjective experience. It is basically given by patients' own experience, and then that can vary in patient to patient, and it can vary in intensity. And so basically, dyspnea is a subjective experience. But why do we need a tool for measuring dyspnea? To We need a tool for dyspnea to measure its intensity and what is the distress associated with dyspnea, and also to monitor the response to interventions, and also to identify appropriate treatment options. So we use various interventions while treating dyspnea in palliative care, but we need to know whether the interventions are working or not. So we need a tool to tell us whether the interventions are working or not, and also to know whether which treatment will be benefited for patient with dyspnea. So according to American Thoracic Society, which is a guideline given for the treatment of dyspnea, they have divided dyspnea into three categories, like a mild, a moderate, and severe category. So they have divided these categories so that appropriate treatment can be given. So for mild dyspnea, basically they have advised to treat underlying disease and also to treat psychosocial factors. For moderate dyspnea, they have advised to treat the underlying disease and psychosocial factors, and also they have advised to help the patient with pulmonary rehabilitation, and also to consider some anxiolytics. But in patients with severe dyspnea, apart from doing the management for moderate dyspnea, we have to add facial cooling by using a fan or oxygen or opioids, or in some cases also NIV, that is non-invasive ventilation. So we need to have a tool to measure the severity of dyspnea in order to identify which treatment will be best for the patient. So that's why we need a tool for dyspnea, for treatment of dyspnea. So there are various tools. I have searched in literature. I have searched various tools. There are various tools, but I have choose a few tools which can be used for OPD or home care setting, and a few tools which can be used for IPD or research purposes. So this is a slide which is showing the tools that can be used for OPD or home care setting, like simple tools like visual analog scale, like numeric rating scale. Visual analog scale can be used in patients like suffering from asthma or COPD, or patient who is ventilated. NRS scale or numeric rating scale can be used in patients suffering from cancer or COPD. Modified Borg scale can be used in patients suffering from COPD, restrictive lung disease, or asthma. And there is MRC dyspnea scale, or Medical Research Council dyspnea scale, which has been used, which can be used in patients suffering from COPD, interstitial lung disease, asthma, and others. And there is oxygen cost diagram, which can be used in patients suffering from respiratory disease, COPD, and heart failure. And also there are a lot of sometimes we also deal with motor neuron disease, and this kind of patients suffer from dyspnea. So measuring dyspnea is important in this kind of patient, and we can use amyotrophic lateral sclerosis functional rating scale revised for this kind of patient. And these are the simple tools which can be used in home care or OPD settings also. So these are this slide is showing the various tools which can be used in IPD or research purpose. I have mentioned IPD or research purposes because these are the tools which can take some time and also needs some kind of expertise while using this kind of tools. So there is for heart failure, we can use chronic heart failure questionnaire, dyspnea subscale. Also for cancer patient, we can use cancer dyspnea scale. For lung cancer patient, specifically, we can use European Organization for Research and Treatment of Cancer Quality of Life questionnaire. It is lung cancer supplement, breathlessness, subscale 4. And for COPD, we can use London Chest Activity of Daily Living scale. For motor neuron disease, we can use motor neuron disease dyspnea rating scale. For heart failure or respiratory disease, we can use RAND instrument. And for COPD, asthma, and bronchiectasis, we can use St. George's Respiratory Questionnaire. And for COPD, asthma, cystic fibrosis, and lung transplant patient, we can use University of California San Diego shortness of breath questionnaire. So these are the tools that can be used for IPD or research setting, or also in case if someone is comfortable, they can use it in OPD or home care setting also. But I have separated this OPD and home care and IPD and research based upon uh, the, the amount of time that these tools can take, and also depending upon the easy to use tools. So now coming to cancer dyspnea scale, this is the, because most of the time we deal in palliative care, we deal with cancer patients, and this is a tool which has been specifically validated for measuring dyspnea in cancer patients. So it is a multi-dimensional scale for measurement of dyspnea in cancer patient, which was developed by Tanaka et al. And it is self-rating, easy to administer, and it measures physiological as well as psychological distress associated with dyspnea. The total score comprises of 3 measures. It measures sense of effort, sense of anxiety, and sense of discomfort. So CDS has been validated in Hindi as well, and I have seen some Marathi version of cancer dyspnea scale also. So it has a total of 12 items, and it measures 3 factors. So the addition of 3 factors gives the total dyspnea score. So there are 12 items. Number 1 item is, can you inhale easily? So patient can ask this question to themselves whether they can inhale easily or not, and they can rate 1 if they can inhale easily, not at all means they can't inhale at all, then they can mention it as 1. They can inhale easily a little, then 2. They can inhale somewhat, then 3. Considerably, then 4. Very much, then 5. Can you exhale easily? Then again same numbers they can give against whatever they feel. And the third question is, can you breathe slowly? Fourth is, do you feel short of breath? Fifth question is, do you feel breathing difficulty accompanied by palpitation and sweating? Do you feel as if you are panting? Do you feel such breathing difficulty that you don't know what to do about it? Do you feel your breath is shallow? Do you feel your breathing may stop? Do you feel your airway has become narrower? Do you feel as if you are drowning? Do you feel as if something is stuck in your way? So these are 12 items that can be used in this dyspnea cancer dyspnea scale. So basically it measures three factors like sense of effort, sense of anxiety, and sense of discomfort. So so sense of effort can be calculated by subtracting 5 from item 4, 6, 8, and 8, 10, and 12. And sense of anxiety can be calculated by adding 5, 7 items number 5, 7, 9, 11, and subtracting it by 4. And sense of discomfort can be calculated from subtracting 15 from item 1, 2, and 3. So this all these 3 factors, if you add these 3 factors, we get a total dyspnea score. So total dyspnea scores ranges from 0 to 48, and total sense of effort ranges from 0 to 20, and total sense of anxiety ranges from 0 to 16, and total sense of discomfort ranges from 0 to 12. So once we get the score, the higher the level of the score gives us the level of dyspnea. So in this from this tool we can know whether the cancer patient is suffering from mild dyspnea or moderate or severe dyspnea. So accordingly we can identify which kind of treatment can be benefited in this kind of patient. So the second disease that we encounter in palliative care is COPD patients. So mostly breathlessness in COPD patient affects their functionality. So this is a tool which measures mostly not the severity but the functionality, that is Modified Research Council dyspnea scale, which is very simple, consisting of just 5 items containing statements about the impact of breathlessness on the individual and leading to a grade from 1 to 5. So it can be self-administered or with a slight change in format of questions delivered by a researcher or clinician. It does not grade breathlessness itself, but the functional impact of breathlessness. So there are 5 items in this MRC scale, and 0 score we give for patient having dyspnea only with strenuous active exercise, and 1 score is given for patients having dyspnea when hurrying or walking up a slight hill. 2 score is given in patients who walks slower than people of the same age because of dyspnea or has to stop for breath when walking at on pace. And 3 score is given for patient who stops for breath after walking 100 yards or 91 meters or after a few minutes. and 4 score is given for patient who is too dyspneic to leave house or breathless when dressing. So this is the scoring system that is used for patients who is suffering from COPD or interstitial lung disease or asthma and other scale. So the most basic tool that we can use for measuring dyspnea is NRS scale or visual analog scale for dyspnea. This is a very simple because it does not take so much of expertise to administer this kind of tools, and it takes very less time when you don't have time and you have to act immediately. So the above picture is showing an NRS scale for dyspnea, that is numeric rating scale. You can see the numbers from ranging from 0 to 10, 0 and 1 being no dyspnea at all, and 2 3 means 2 3 or 4. If the patient is telling that I have dyspnea 2 3 or 4 out of 10, it means that patient is having mild dyspnea, and we can choose the appropriate treatment according to the score. And if the patient is having 5 6 or 7 score out of 10, then we can make it as a moderate dyspnea. And if the patient is having 8 9 or 10 score, then that the patient is suffering from severe dyspnea. So we can modify our treatment accordingly. The below scale is visual analog scale. I have modified a little bit of this scale. So the leftmost that bar you see, very small bar, that means the patient is having no breathlessness, and you can see that the bar size is increasing when you go on the right side. So the patient can choose the bar according to their breathlessness. So if the patient is choosing the rightmost bar, it means that the patient is having the severe maximum breathlessness.
Hello and good morning, everyone. Welcome to the last section of the session on instrument, where I'm going to discuss about confusion assessment method, the tool for delirium. Now, as we all know, delirium is an acute disorder of attention, cognition, and psychomotor activity that affects elderly and is found to be 3 to 29% in the hospitalized adult patient. Its co-occurrence with dementia is as high in hospitalized patient as 22 to 89%. When superimposed with dementia, it has shown to prolong hospital stay and is associated with both cognitive and functional decline. We also know that delirium still remains under-recognized and is often misdiagnosed. Now, delirium independently is associated with increase in the hospital stay of the patient. Inpatient mortality increases, long-term mortality increases. There is decline in cognitive function of the patient, and there is increased requirement for institutional care of the patient. Even the functional impairment, the healthcare cost increases, and it causes distress to the patient and the family. Therefore, we need to evaluate and manage delirium as early as possible. There is a systematic review by Grover and Kate in 2012, which comprehensively identified and evaluated 38 separate instruments that is used for screening, diagnosis, and knowing the severity of the delirium. Now, let's go through some of the instrument that is used for assessment of delirium. There are various criteria by which it has been classified, but broadly, I'm just classifying it into a few criterias. That is, instrument for assessment of irritability of the patient, Richmond agitation sedation scale rash, instrument for screening for premorbid cognitive disturbances, IQ code, that is retrospective informant questionnaire on cognitive decline in the elderly. Then there is screening instruments are there, which include NICAM confusion scale, nursing delirium screening scale, delirium observation screening scale, or delirium observation scale, or even CAM can be used, to name a few. Diagnostic instrument, to name a few, includes delirium symptom interview, memorial delirium assessment scale, confusion assessment method, CAM ICU, pediatric CAM ICU, or clinical assessment confusion A and B. Even delirium rating scale, revised version 98, can be used for diagnostic instrument. To know the severity of the delirium, a few scales that can be used is CAM confusion assessment method, delirium rating scale and delirium rating scale revised 98, CAM ICU, delirium ometer, delirium index, memorial delirium assessment scale, delirium assessment scale, or delirium severity scale. Now, CAM proper. Confusion assessment method, CAM, is created in 1990 by Dr. Sharon Inoue. It is most widely used tool for identification of delirium, since it provides a quick, accurate, and standardized approach. CAM is a diagnostic tool developed to allow physicians and nurses to identify delirium in the healthcare settings. It is based on the criteria of DSM-3 revised version. Then CAM rates 4 diagnostic features, which include acute onset and fluctuating course, inattention, disorganized thinking, and altered level of consciousness. It was designed to be brief, less than 5 minutes to perform, and has been translated into more than 20 languages and adapted for use across multiple settings. CAM, as we know, is used as a structured patient interview, which includes test for attention, memory, uh, orientation, and patient self-report of delirium symptoms. Rater qualitatively and quantitatively scales to record whether 12 delirium features are present, their severity, and if the features fluctuate during the interview. The 12 evaluated features are one is acute change, inattention, memory impairment, disorganized thinking, altered level of consciousness, disorientation, perceptual disturbances, delusion, psychomotor agitation and retardation, sleep-wake cycle, and inappropriate behavior. Delirium is detected using an algorithm based on 4 of these features. CAM diagnostic criteria is fulfilled by the presence of either acute change or fluctuations or inattention. This uh, acute change or fluctuation and inattention has to be present, and either of the disorganized thinking and altered level of consciousness can be there. Now, severity of delirium is calculated using CAM scale, which considers all features of the CAM except delusion and inappropriate behavior. 4 of the CAM features are eligible for determination of fluctuations, which include inattention, disorganized thinking, altered level of consciousness, and psychomotor agitation and retardation. Inattention, as we know, can be tested directly by asking the patient to recall the days of the week backward or months of the year backward, or repetition of the digit in forward and reverse sequence. It can also be observed during the interview if the patient has perseverating on a previous question or requiring questions to be repeated. Then disorganized thinking. It can be assessed via qualitative evidence, including but not limited to faulty reasoning, illogical thought patterns, tangential or circumstantial speech, poverty of thought, nonsensical speech, or evidence of severe disorientation. Altered level of consciousness is defined as increase and decrease in responsiveness to the stimuli. Now, confusion assessment method instrument proper, in which there is acute onset is there. Acute onset can be assessed uh, acute change in mental status from the patient's baseline. Inattention can be tested by difficulty in focusing attention, like patient is easily being distractible or having difficulty keeping track of what was being said. If both are present, if present or abnormal, does this behavior fluctuate during the interview? That is, tend to come and go or increase and decrease in severity. Disorganized thinking can be tested by looking at the patient if he has rumbling or irrelevant conversation, unclear or illogical flow of ideas, or unpredictable switching from subject to subject. Altered level of consciousness varies from alert, vigilant to lethargic, stupor, and coma. Disorientation can be tested through time, place, and person. Memory impairment should be also evaluated during the interview, as many memory problems during the interview, such as inability to remember events in the hospital or difficulty remembering instructions. Perceptual disturbances are looked into, whether the patient is having hallucination, illusion, or misinterpretations. Psychomotor agitations, such as increased motor activity such as restlessness, picking at bedclothes, tapping finger, or making frequent sudden changes in position, or psychomotor retardation such as sluggishness, staring into space, staying in one position or for a long time, or moving very slowly, can be evaluated. Then altered sleep and wake pattern is to be evaluated, which shows that daytime there is excessive sleepiness and at night there is insomnia as well. Then confusion assessment method, that is diagnostic algorithm. It includes feature 1 and feature 2, and either of feature 3 and 4, that is 1 and 2 is acute onset or fluctuating course has to be present, along with inattention, and either of disorganized thinking and altered level of consciousness is present. Now, comparing CAM with some of the other tools, we know that uh, uh, it has been modified and adapted into various other tools, such as and for other settings, such as modified CAM ED that is used in emergency department. It has 3-step assessment and requires 4 to 6 minutes. CAM ICU is used in the ICU settings. It has 4 criteria and requires 2 to 5 minutes. Its specificity is very high, that is 98.6%. Then DTS is there, delirium triage scale, which is a 2-step assessment, requires only 20 seconds. Its sensitivity is very high, that is 98%. Now, brief CAM is there, that has only 4 criteria and requires 2 minutes. Its sensitivity is 78 to 84%, but specificity is up to 97%. NICAM is there, which has 9 items and requires 10 minutes. Its sensitivity is 95% and its specificity is low. RASH is there. RASH has 10-step assessment but requires only 30 to 60 seconds. Its sensitivity is very high, as 99%. Now, CAM has been adapted into various other tools such as CAM short for all settings, CAM long, then CAM severity short and CAM severity long, which can be used in all other settings. Then it has been also used in other settings like BCAM is their brief confusion assessment method for emergency department. CAM-ED is there for emergency department. Modified CAM-ED is there for emergency department. For nursing home, we have NH CAM is there. Then there is FAM CAM is there. FAM CAM is used for family confusion assessment method. Then 3-minute diagnostic confusion assessment method is there. Then ultra brief confusion assessment method is there. This can be used for all setting. For ICUs, we have CAM ICUs, which has been validated into multiple languages. Now, then what are the strengths of CAM? As we all know, CAM can be used for different settings, but it is the important things are it is very quick, accurate, and standardized approach. Users are used as both screening and diagnostic tool. Requires less than 5 minutes to perform. It has been translated into more than 20 languages and has been adapted into different setting. Has high sensitivity and specificity. Used for both clinical and research setting. And it is adapted for use across multiple settings such as ICUs, emergencies, and patients and inpatients. Now, what are the drawbacks? Drawbacks are it requires some training to use the tool, and it is not able to differentiate between delirium and dementia, and it is not able to assess the severity of the delirium unless we use CAM S tool. Now, to summarize, we can say CAM is a both screening and diagnostic tool and requires 2 of the important criteria, that is acute and fluctuating course and inattention has to be present, and either of the two has to be present, that is CND, that is disorganized thinking and altered level of consciousness. Thank you.
So we still have 15 minutes for the question and answer sessions as we had planned. Lulu, madam, there are some questions in the chat box. Would you like me to go over them, or would you like to take over and ask the and talk to the speakers? I am not able to hear from Lulu, madam. So I'll just start with some of the questions. Is madam here? Yeah. Lulu ma'am, we cannot hear you. Am I audible? Megha?
Yes, you are.
All right. So I'll just start with you. Megha, the questions for you were based on validation. I think you had answered them. And would you like to add anything more to that?
So yeah, I did try to find some that if we have some validated versions in Indian languages. So I could not come across any validation studies as such. However, there are a few studies like the Hindi version and the Punjabi version that I showed in my presentation. I got that from a supplement from a study that happened in PGI Chandigarh in lung cancer patients. And it was marked as Alberta Health Services. I think it must have been, probably translated and validated there. And then I also found a few studies like in Bangla and others. They have used it, like translated and used, not really validated.
All right, thanks. And a lot of questions were from Dr. Babita. So I thank you very much, Dr. Babita, for your questions. I'll try to go through them. And if I miss any, please feel free to button. And there was another question for you, Megha. Do you use unable and incomplete in the ESAS when you're not able to, that you're not able to complete the ESAS when the patient has, we've heard of using the word you and I as unable and incomplete. So when you cannot, because usually we assess the physical symptoms, but when it's done by a proxy or caregiver, we do not touch the psychological symptoms.
Yes, that's
so true. We write it as incomplete or unable.
So as I told you, we in our setup, we have customized our symptom assessment as we do not really assess depression and anxiety daily and objectively, like in our daily symptom assessment. So, but yes, that's true. If the proxy, like a caregiver or a nurse practitioner is doing it, so in that case, we will omit that thing, the depression, anxiety thing, and the feeling of well-being. Yeah, we do.
Thanks. Thank you. Thank you for that. And I'll just go to the next, I'll go in order of the questions that were asked. So Avinash, your questions were about how do we handle doing the PPI in a busy OPD? And it was a very nice presentation, and I think very valuable for us in the home care scenario or in any scenario to use the PPI. So could you tell us a little about your experience and how nurses do it? Thank you.
Thank you so much, ma'am, for the question. Ma'am, one thing about the using it in OPD, ma'am. So PPI has already been validated in hospital setting, maybe OPD, IPD, and it has also been validated in hospice setting. Ma'am, using it in busy OPD is actually very easy because we have done in our busy OPD in Tata Memorial Hospital, because anyway we are taking the history of oral intake, edema, dyspnea, delirium as a part of ESAS or non-ESAS symptoms. And we also record performance status of the patients, activity of daily living, level of consciousness. It's just about integrate that and putting into algorithm. So, and that's why PPI is very easy, and that's why we choose it for our study. That was our background for choosing the PPI as a part of our prognostic tool, developing a prognostic tool model or validating a prognostic tool model. So it contains many of the most of many, all the parameters are objective in this tool, and none is subjective. What we have in PAP, there is a clinician prediction of survival. And so it doesn't actually incorporate the experience of the clinician or healthcare worker. Perhaps incorporate clinician prediction of survival. That is how PPI is, I think, more practical than PAP, because the objective tool can be administered by any healthcare volunteer, be it physician, be it nurse, or be it a trained volunteer. So yeah, administrating PPI in OPD setting is very easy, feasible, and very applicable, can be done at bedside, can be done at OPD, ma'am.
Thank you very much, Avinash. That was very valuable. And I think all those points that you said were valid. We assess all those symptoms. It is just that if we can put it together, we will have a great, we can actually have a very, very nice tool, which can be readily used. Thank you, Avinash. And moving to Puneet, because the next questions were for him. Your questions were on what is painful cold, and what are the limitations of using the DNR? And so, Puneet, yeah, the DN4, sir.
Yes, ma'am. Cold basically is a noxious stimuli, as we all know, and the painful cold here meant was the sensation of cold by any cold stimuli. Basically, it's a term known as allodynia, where pain is evoked by non-painful stimuli. It's a it comes under the characteristic of hypersensitivity, which is a very important characteristic in neuropathic pain. Now, coming to my second question, that is limitations of DN4. Limitation of DN4 is that in 10 to 20% times, the neuropathic pain is under detected or over detected, because what happens is that all physicians are different, and it depends upon the expertise and the way you ask the question. So as assessment bias is seen in few of these cases. Second limitation is that when we approach a patient with this pain, if he has pain in multiple sites, but what we ask is that which part of the pain is the most disturbing. So we tend to take the questions related to that part. So again, the assessment bias will be in this. And thirdly, in these screening tools, what happens is that this is initial screening tool. So proper history and proper examination, proper sensory examination are missing. So what we do is that if we what we tend to do is that we take a simple screening tool, that is DN4. Once we find that yes, the score is greater or more than 4, we say that yes, it may probably be a neuropathic pain, and then we complement with proper assessment tools. A few of the proper assessment tools are neuropathic pain scale and McGill questionnaire. So we go on further. I think I have done answer.
Yeah. Thank you, Puneet. Moving on to Nandan. Nandan, your question was on how does the NRS and VAS is patient subjective. So that's an answer I think you can go ahead with. I also have a question for you here in the cancer dyspnea scale. How difficult, because we've used it in our setting for a study. So how easy was it to administer it? Because the first 3 questions in the Likert are in reverse order. So what was your experience about using it? And could you tell us about the ease of using that scale and its limitations? I might have to switch off my video in between because of the bandwidth. Nandan, please.
Yes, ma'am. So first question, ma'am, that NRS and VAS scale. NRS and VAS scale, why I choose is that because it can be used, ma'am, in most of the setting, because most of the a patient that we look after is like home-based or OPD-based only. Most of the time, we don't admit the patient for like inpatient. I mean, most of the time, 80% of the time, we see the patient in home care setting or in OPD setting only. So the most, important focus would be on using NRS and VAS scale, because this is very easy to use. And cancer dyspnea scale can also be used in cancer patient, but actually we don't have time sometimes. So we can rely on this like NRS and VAS scale, because it can be administered by the patient. We can ask the patient how much is your dyspnea score out of 10, and so that they can answer like if the patient is having like 9 or 10. Then we know that according to American Thoracic Society that if the patient is having severe dyspnea, we know when to use opioid, because sometimes we don't know when to use opioid, and we might end up giving someone having mild dyspnea or moderate dyspnea opioid, and patient might suffer sometimes, because opioid can be very tricky sometimes in this kind of patient. So so it's not physician subjective, it's patient subjective. So if the patient is telling that the patient is having severe dyspnea, so it means that the patient is having severe dyspnea, and we don't have any other options, I think, when you look at this kind of patient. And also coming to cancer dyspnea scale, as we know that there are 12 scales, and this scales is actually validated in Hindi version also. Someone using this scale has to be very familiar with this like questions and this like rating, like not at all, a little, or somewhat, considerably, or very much. So this can be time consuming, and it can be very difficult in some in like a OPD setting or even in IPD setting also. But we have to choose when to use this kind of scale. So I think I would recommend that this kind of tools can be useful only for research purpose, or when you are using for sometimes we are very unsure whether to use opioid or not in some kind of patient. So when we know that this VAS scale or NRS scale might not give you the accurate understanding of the severity of the dyspnea, then in that cases in cancer patient we can use this cancer dyspnea scale to know before using like opioids in this patient. And it won't take, I think, more than 5 minutes, maybe more than like around 5 to 7 minutes to use cancer dyspnea scale, and we can get three factors like sense of effort, sense of anxiety, and a sense of discomfort in this kind of tools.
Thank you, Nandan. So, any of you have anybody would like to share in their experience? Because it's hard to ask a patient to have mild, moderate, or severe dyspnea. So, using the MMRC for that actually is helpful. Using the questions from the MMRC to, tell them, is it at rest or is it when you're walking? And so that way in NRS, VRS, and when you actually have to do an inpatient dyspnea scoring, then your cancer dyspnea scale, when you have time to sit and administer the scale or in a research setting, because one has to really know that scale well. The first three questions in the Likert are the opposite, and the questions after that are the other way around, and even the calculation of the scores.
Even if you look at the first question, you'll get confused sometimes.
Yeah, exactly. So I think more important is that we have to be very thorough about the scales and then use it, because this is definitely not a scale you can tell a nurse or someone to just administer.
Because sometimes in home care setting also, I mean, sometimes
it's
difficult, yes, ma'am.
Yeah. And when you ask questions like, do you feel if you're drowning, then it becomes a little tough to ask those questions. That was my practical experience. Dr. Pushpalata, I can see that you have joined. So please.
Just one question I want to ask from Dr. Nandan, that are you able to, in lung cancer patient, to calculate or see the dyspnea, how much the dyspnea is they are having, and observe?
Sorry, ma'am.
In lung cancer patient, how you are doing the dyspnea scale and how you are managing that in lung cancer, not other cancers.
Yes, ma'am. Lung cancer, they have specifically, I have seen in the literature, there is a specific like tool called European Organization for Research and Treatment of Cancer Quality of Life. So they have mentioned this scale for lung cancer, but I think for practical purpose, ma'am, again, same thing arises. Where are you using? Whether you are using in IPD or OPD setting or home care setting. So it might not give you the accurate results sometimes. So, but practical purpose, I think, ma'am, NRS and VAS scale would be the best tool. But it can for when you are using some interventions like that.
Yeah, it is usually very difficult to assess the dyspnea in lung cancer patients.
Yes, ma'am. So, ma'am, so I have also mentioned about American Thoracic Society guideline, ma'am. So mild, moderate, and severe dyspnea. So sometimes, like most of the time, we have studied that opioid can be used for dyspnea, but we don't know when to use opioid, like accurately when to use opioid. Where I have seen some patient opioid acting very trickily in patient. Suppose someone might prescribe opioid for mild dyspnea also, but it might not help. It might deteriorate that patient's dyspnea also. So we need to know when to use opioid also, and for that we need to know severity of the dyspnea. And I think VAS and NRS can give us somewhat like the severity of dyspnea.
Any experience with haloperidol or?
Sorry, ma'am. Haloperidol.
Any experience haloperidol for dyspnea and terminal dyspnea? How to manage that terminal dyspnea?
No, ma'am.
Terminal breathlessness.
Terminal breathlessness. No, ma'am. I haven't used for haloperidol for terminal dyspnea.
Because oral opioids are difficult to give at that time. So, which type of you will prefer? IV medication or?
Yeah, IV medication. Definitely, ma'am. IV medication. We can give.
IV opioids. IV opioids.
Yes, ma'am. Yes, ma'am.
Or you want to add haloperidol also?
Yes, ma'am. We can add haloperidol also if the patient is suffering from that delirium and all, or there is so much of agitation, or if there is some anxiety component also, then we can add anti-anxiety medication also. So depending upon the patient's other conditions also, ma'am.
Okay. Thank you, Dr. Nandan. Very good.
Thank you, Nandan. Yeah, thank you, madam. Is Dr. Lulu madam here? Because we are in the last minute. Aarti, we really appreciate your slides, and we know that you've done a lot of work in using the NCCN distress scale, and so we are really thankful. Do you have anything to add? You have a few seconds if you want to add in anything from apart from your presentation, Aarti, if you can still hear me.
Thank you, ma'am. Thank you so much. I want to add just one point that a distress thermometer is very, very basic and very easy tool to implement. Like we can implement in the OPD, IPD and waiting area also. And for the implementation of these tools, we can use the our social worker, nursing staff. We can train them very easily. And as I told in my presentation that the DT thermometer, distress thermometer is a very good means to understand the patients, how to deal with them in what intervention the patient need in further. So here I can say that we should use distress thermometer to assess the distress in the OPD, IPD and OPD, IPD settings in a regular clinical settings, regular practice.
Thank you, Aarti, because I think that was a word we were looking for in this entire session, that each one of these tools is longitudinal assessment. So in every setting, when we use the tools, that is when we get the best results of our tools. It's not a one-time tool. I will have to break you from here. And Kunal, just last words from you. Thank you, Aarti. Kunal, because we have almost overshot time. Thank you for bringing it up.
Thank you, and thank you, everyone. See, I would just like to say I haven't used CAM any time earlier, but since I have read about it for this session, and we are planning to start, we are collaborating with the ICU team, our ICU team, our oncologist, and we are trying to do a study on delirium because we see a lot of patients over here at our hospital in MPMCC. So we are trying to assess using CAM. We are trying to assess the delirium in the patients, and that will be with the collaborating with the ICU. That is only I want to say, ma'am. Before I haven't used.
Thank you, Kunal. So once you do the RAS, you can do the RAS and then do the CAM.
Yeah, with the RAS only, using the RAS.
You screen with that and then you do the CAM.
Yeah. Thank you so much.
That's very nice. Lulu, ma'am, if you're here, last words from you. Otherwise, I will have to wind up this session. Thank you so much, Dr. Pushpalata Garu. Thank you very, very much, each one of the speakers. I know we bothered you a lot for your recordings, but we needed all of it in time and it finally fell into place. And dear Dr. Pushpalata Gupta and Dr. Lulu Matthews, thank you for your presence. And with that, I think we will close this session and we hope that we will be able to use our tools in assessment way better than what we are already doing. Thank you very much.
Thank you, Dr.
Everyone. Thanks, Dr.
Thank you so much.
For the support.
Thank you, ma'am. Thank you, ma'am.
Looking forward to the conference.
Yeah.